everyone, and it's been a little while since we've done an Unfiltered production, but we had the opportunity to read the study that JAMA put out recently, and I posted it in our newsletter, and I wanted to take a moment to do an Unfiltered on this because Cindy is with me today, and we read this study, and we had some distinct thoughts on the study that was done by JAMA. It seems to be a very thorough study. It looks at over 22 million claims, or what they call spells, Cindy, which are the episodes. And they drew some conclusions based on the information that they saw that was coming off the data collected by the agencies versus what they were seeing on claims data. Cindy, tell me about initially when you read this study. And those of you that want the study link, it's going to be in the newsletter with this podcast. Cindy, tell me about what first jumped off the page at you when you read this study.
Well, I had the opportunity to be on one of the previous technical expert panels when value-based purchasing was still in its pilot phase, when you had the initial small group of states. And as they presented their initial findings, I asked the same question that was then found in this study, which was, wait a second, so you're demonstrating that the functional outcomes are better than states that are not in this pilot phase, but their rehospitalization rates and their ED rates don't look better. So that doesn't really make sense to me. And I was clear with the group, bias. I'm a therapist. Maybe I'm just missing something. But it doesn't make sense to me that if you're saying you figured out how to improve the quality of the care and management of functional problems, thus more patients are better than when they started, why would that not have some relationship to keeping them out of the hospital or keeping them out of the ED? So when I came across this study, I almost immediately sent it to you because I'm like, hold up. We've been looking at this saying something just hasn't felt right about some of these quality initiatives in terms of, is it really capturing true changes in patient care, or has it fallen victim to gaming with respect to, we sometimes see better performance on the measures that are coming directly out of the OASIS, where we control both the initial answer and the final, and versus claims information where we don't have as much control.
And Cindy, it was interesting because one of the things I said to you when we first discussed this was that it almost is saying the quiet part out loud. Mm-hmm. Okay? And that's a scary place for, as a provider, you should think about this as a warning. That CMS is getting better at deciphering the data that they're able to access. Gone are the days of analog billing. Gone are the days of paper anything. Gone are the days of not connecting the dots between, say, an OASIS and a final claim, that the OASIS was separate from that in some of the data. The jig is up. That's the way I read this study. And some people who are going to listen to this podcast in the quiet of their own space are going to know that they're part of the problem, that they artificially increase and decrease items on the OASIS document based on some sort of way to either A, improve the money that they're going to get up front, or B, improve their outcomes, or C, improve their stars. And let's go through the rest of the ABCs, right? It just needs to stop. It needs to stop. It needs to die a death, and understand that every regulation that we're looking at, from the MedPAC cuts that every year they suggest a cut in home health, how much stuff that CMS is taking out of our hands, i.e. they're not even allowing us to set goals on the GG items coming up in value-based purchasing. They're going away from the scores and the functional items. Cindy, can you kind of connect the dots for folks that are listening to this a little bit because it's a very, very involved study, but I think that, just the jig is up. The quiet part has been said out loud. And can you kind of connect the dots and how CMS is going to use this information and better information going forward?
Well, I think we're at a crossroads with the data right now in terms of there's so much of it that's accessible to CMS, but at the same time, they don't seem to be able to land on what they think we're doing improperly. Case in point, whenever we see a proposed rule, and one is going to be coming out shortly to determine our fate for 2025, but they love to talk about behavioral adjustment and how the functional scores seem to move around too much, and that they have to recalculate points, and they believe we need additional pay cuts on top of this because of some of the choices we've been making with this. But then at the same time, they use those exact same questions in quality models. And it was one thing in star ratings, because star ratings, we know they're seen as important, they're public facing and all of that, but there really hasn't been a direct financial connection to them. There is in value-based purchasing. So wait a second. So you're telling me with one hand that I'm a cheater and deserve a behavioral adjustment, but with the same information, you're using that to identify who you're calling the high performers so that they get a revenue bump in value-based purchasing. So wait a minute, the data is suspicious here, but accurate here, and it's the same items. I don't understand, Sherry. It's like, pick a lane. Either we're cheaters and you need to make different measures that we can't mess with, or we're not, and that's accurate data, so stop accusing us of cheating and stop trying to give us pay cuts.
I think that is a great statement. And I think that folks that are listening to this Unfiltered podcast have to understand that Cindy and I had a very heated conversation about this on Friday, and we made a decision to give ourselves 48 hours before we recorded this podcast, because there were some words that were not public friendly that were used, because every single day, the folks that are listening to this, every single day, we see a new attempt at a new way to change data and to improve their stars, outcomes, value-based purchasing, monies, whatever. And I think if I'm CMS, I try and put myself in CMS's shoes. What else are they supposed to do? What else can they do to make sure that we're accurately reflecting that patient, that beneficiary, that person that needs care back to them? We are alone in that house. There are no other people there unless we have somebody that's co-treating with us or being precepted, or perhaps the aide is there while the nurse is there, the therapist is there. We are on our own in that home without any kind of oversight, without a peer professional next to us in the nurse's station. We don't have a peer professional in the clinic. We are being given the trust to go out and see these patients that are probably some of the neediest Medicare beneficiaries around, in that they want to stay home. CMS is dying. They're begging at this point for us to accurately represent that patient and what the costs are and what the needs are. And I think, and I said to you guys, I kind of said it to you the other day, and I could rant on this for a while as a former agency owner, and I want to kind of close with that story. But what is it the CMS could do? Could they make you hire minders? Could they make you hire some government and contracted employee that would go out and do spot checks and make sure that the visits are happening like you say they're happening, that would go back and take an OASIS and make sure that it looks like the patient that you just saw? What else? I think I'm feeling some empathy for CMS, and that doesn't happen very often, but just what else can they do?
But I think part of it, Sherry, is there is a gap in that quality metric system, and that is the lack of auditing. So to look at it and say, well, we're going to take this information and create value-based purchasing or stars, you would think there should be some mechanism that folks that are performing excessively well or more than expected should be audited. Yes. I'm not saying torn apart. I'm not saying, assumed guilty. If you found some magic solution that really, really improves the quality of patient care, then I don't think it should be, held off from everybody else. Give everybody else the opportunity. One second. I'm so riled up, I'm going to start. Anyway, audit them. Find out if that's accurate. What is the secret sauce? How is this really working? Because if you get audited and it's completely valid and supported and well documented, that no harm, no foul. But when you sit there and look at value-based purchasing right now and say that the top performing agencies have a 99% success rate in improving dyspnea, what? How? What kind of patients are we serving? I don't understand. So the auditing piece is part of it. The other, I think, we're seeing with that move to the GGs, and this is our cautionary tale today, because we've seen a track record of OASIS data shifting when it gets used for different purposes. Mm-hmm. And far too many agencies were kind of sitting around saying the GGs weren't really doing anything.
They didn't matter.
We've been told that. They didn't factor into reimbursement. They weren't really part of anything. We didn't really check them. We told the clinicians, to do their best, but we didn't really put an emphasis on it. Now I'm hearing, well, now we have to teach about the GGs. What are you going to teach about the GGs? We got to focus on the GGs. And I'm thinking, oh, please, please don't let this happen again. Please don't now go from, because it's a subset of the GGs and they're very specific tasks. They're not all G130 and GG170. So you're talking about rolling, sitting up, standing up, things that many of our patients have to be able to do to come home anyway. What we can't have happen now is everybody in home care, nobody can roll anymore. I mean, we already saw that happen when eating got pulled into a quality measure payment related thingy, and all of a sudden people can't feed themselves anymore. So we have to make sure we stick with the mantra K&K has had since day one, and I've had for 2 decades of my life. Every time point, every item, every time has to be the best possible answer following official guidance. And I'm seeing more of these tools and resources floating around. Always check it against official guidance, because there are things that can get people into trouble that they heard one time at a conference, or they swore they saw on this piece of paper one time, and they spread it all in the agency that this is how we're going to do it now. I even say, and you know this, Sherry, if anybody ever says, I think Cindy Kraft said, please email me. Please, I want to be able to clarify that, because we cannot cut the corners on this and fall into a trap that says, okay, CMS already thinks we manipulate it. The study implies we manipulate it. GGs have not really been part of this till now. We have to make sure we're doing it correctly and accurately, and not the temptation of, well, I'm going to make sure now nobody can do any of these things. And back to what you said earlier, Sherry, is they are taking some of this out of our hands. Not using the goals column and going through essentially predictive modeling by looking at a variety of risk adjustment factors. We can't tell them what we think it's going to be at discharge. We just need to do the best we can to address those issues appropriately and make sure that the data is collected accurately. But I think this is going to be interesting for OASIS measures to be only we control the beginning. We are going to report the end, but against the target that we don't set.
And we're not saying that there can't be a different emphasis on GGs and,
Right.
and more accurate emphasis on GGs. You'll never hear us say that. And we're not saying it, but we are saying this. They have the data from the facility that the patient was in before, guys. Every single patient had these GG items either at the hospital or at the skilled nursing facility. So they have something to compare it to before they got to the home health agency. And that's an interesting place to be, because in the skilled nursing facility and in the hospital, they have adaptive equipment available to them that they may not have at home. So there might be a decreased ability compared to the skilled nursing facility to transfer in and out of a bed, because now it's a bed that doesn't move. It's a bed that doesn't have an elevating headrest or leg rest or all that other stuff. You have to spell that out. If you see those discrepancies, you need to document it out. This patient came out of the skilled nursing facility with supervision only for rolling, but now they're at home. They need min assist. Why? You have to spell it out now, and you can't keep gaming this. I think I get so passionate about it, Cindy, because I used to own a home health agency in Central Florida for 10 plus years. And when outcomes first started being reported on our quality outcomes, one of the things I noticed is that we were competing against agencies that did not get a single functional item better, but had low teens on their hospitalization readmissions. What? All their functional items were not improving, but yet they were keeping them out of the hospital 3 times better than my agency was, despite the fact that we were improving their functional items tremendously. As a small agency, it was extremely frustrating because it wasn't true. It's not true. This data has been designed to say A plus B equals C, period. And we have said, no, A1 plus B2 plus, I'm going to put a little bit of sauce on that, is going to equal something else. We've created this mess, and we have to change our lane to improve it, because I'm going to tell you, CMS is getting smarter every single day. And with the advent of AI and some of the predictive things that they can do, Cindy, I can see a day where all of this goes out of our hands. And that's one of those things that's kind of a scary place to be, that you would receive a patient that was pre-assessed, and you would receive what your money was going to be without you ever even going and seeing a patient. And so think about it from that perspective, everybody. Think about where CMS is coming from and why you're seeing some of these disconnects on their data mining and the things that they're able to do and how it's impacting our industry. Cindy, what do you think agencies should do now?
What I want to address, Sherry, is we have listeners that are like, listen, I have never gamed it. We have always followed the guidance. I've always done the right thing. I think we got to acknowledge that that may also mean you're a 3-star agency. You're a 3.5-star agency. And I totally appreciate the frustration when you're saying, well, how do we get to 4? How do we get to 4.5? I want to be a 5. This star rating thing has never worked like a restaurant or a movie. You can work your tail off and not get more stars because it's all done on a curve, and it says the majority of agencies are supposed to be 3s and 3.5, which then you go to the consumer and say, who wants to go to a 3-star agency? Well, I don't. I'd rather have a 5-star. That's been all convoluted since they chose that icon to begin with. But K&K is here to support the ones that do the right thing, even when it's hard and even when it's frustrating. And it can be incredibly tempting to say, if I just kind of didn't report that, my rehospitalization rates would look better. All right. But we know many, many people would never do it. I want to just commend you for your integrity and your dedication to good patient care in the face of feeling like it's an uphill battle. These quality measures don't measure what we think they do. And I think this leads to my big suggestion now is we've got to watch for that proposed rule for 2025 and be prepared to comment with a vengeance on anything related to quality in terms of real life examples of impact on patient care, on the agency, on integrity, all of it, because I think we have to be more engaged in the process and not just kind of complain from the sidelines or give up and assume that they're just going to do whatever. I do think CMS is in a tough spot, but they need to hear from more people, real people in the agency, about how this affects them and suggestions of what you think would be better. New OASIS questions. I mean, come on, the ones that they keep using were in it when it started. Don't we all change measures after a while? Not the same questions that we've been using for 2 decades. But I think we need to be actively engaged in any opportunity to comment related to these quality initiatives.
I 100% agree. And normally that rule comes out somewhere in or around July 4th. And July 4th is coming up. I mean, it's less than 2 months away, or it's right at 2 months away. And once it comes out, we get 90 days to comment. And I can't tell you how important it is, not just that you comment from an agency or a professional organization level, but that you write down a letter, dictate a letter, and send it electronically to say what your challenges are in how you meet your patients, because the patients are for sure coming home sicker. The other facilities, their rules have already come out. I would recommend that you read their rules, because oftentimes they will be a harbinger to what's coming in the home health rule. And I hope that their pay increases is one of the things that comes with the home health rule.
Yeah. SNF and IRF are getting increases. So, fingers and toes crossed, maybe we finally get one.
But reading this study, it's not good timing for this type of a study to come out while they're in the middle or at the end of writing our proposed rule. So be prepared to comment and recommend that your patients comment, especially your patients that have had great outcomes from the way that you provide home health. But and I just go back to, I think that this study is going to cause other studies. This was just the first one. It's going to be the beacon that the rest of the folks are going to try and fill out the gaps that might have occurred in this study. So everyone be aware that this is out there, and CMS is aware, and they're becoming more aware. And I think that it's just super important that we, like Cindy said, maintain our integrity and maintain our accuracy, and that we owe that to the patients that we serve, and making sure that they get the benefit that they need. Cindy, do you have any closing thoughts as we close off this thing? Because I'm going to probably need to go have a say, have a kumbaya or something.
It's just, I think you're right. More information, more data is available. And we can only control what we can in our agency. And that is making sure every time point, every time, every opportunity, every code is following all the rules that it needs to and accurately describes your patient to the best of your ability.
That's a great way to end this. And I recommend everyone who is enjoying these podcasts that you subscribe to our YouTube channel. We are constantly uploading free information, and our Unfiltereds are simply a way that Cindy and I are able to vent and to get out the frustrations and to explain why it's so impactful to what we provide every day. So thanks everyone for listening, and be safe out there.